So we'll give them a few minutes to come in, even though, hi everybody. Okay. So my name is Sydney. I'm representing Aesthetic Professionals tonight. We are an education center and distribution and dental lab located in Tarzana, California. Elisa, do you want to take it from here?
Absolutely, absolutely. I'm Elisa from Shining 3D. Thank you all for joining us. I'm glad you could be here for the Shining 3D Dental Suite presented by Dr. Isaac Towell. A big thanks to Aesthetic Professionals for hosting tonight. Without further ado, I'm going to pass this over to Dr. Towell, our incredible speaker, who's going to share his background and experience using the Shining 3D technology. Dr. Towell, get this webinar
Thank you,
started.
guys. All right, thank you. And thank you, Aesthetic Professionals, for having me on tonight. Looking forward to introducing you to some of the concepts. And more importantly, whenever talking about a concept, I think it's the most important to show the actual process, how we're actually completing all these types of cases and the uses that we can have for it. And then from there, hopefully you'll see some of the value in a lot that Shining 3D has to offer. My name is Isaac Towell. I'm a dentist practicing in Brooklyn, New York. I've been practicing for the last 20 years in dentistry, whether it be analog or digital dentistry, and I've been lecturing for quite a long time, and I've been having a great time playing with the different technologies that are existing inside of this Shining 3D workflow. Let me just try to fix that because I think my screen was not playing. Okay, so can you guys see that? Or does that disappear again? Let's see. I think it disappeared. Okay, let me
It did.
open that back up. Yep. Let me open that back up, and I will. Let's see, after all that trial, and then that happens as soon as you press play. Kind of funny that way sometimes.
Oh yeah.
Let's see. Okay. FP1 versus FP3. There we go. Let's try that again. No, did it again. Okay. Hopefully you can see that now.
No.
No.
Let me look and see if there's a way for me to force it. There's not. It says you're the presenter.
Huh. We were good a minute ago.
Yeah.
It was working great.
That's interesting. Let's see.
Okay.
Oh, there it is. Now it's saying it's paused. Let me try.
Oh, yeah.
There we go. It's here.
Okay, how's that? Are we better?
Yes.
Yeah. Yep.
Okay. Oh, and it disappeared. Wonderful. Let's try that one more time. Okay. Hopefully this is going to work now.
Wonderful.
Okay, I think we're working.
It's working.
Okay.
Finally. Okay, so just a little bit about the digital revolution. So hopefully you got to hear the music with that as well. One of the webinars I played recently, they couldn't hear the music, so hopefully you got that there. I think the point of what I was trying to show you is that we are in a time of change, drastic change in dentistry, where we're evolving from this analog stone model world, moving on to this incredibly wonderful digital world, where literally everything is totally at our fingertips. And if you read the famous novelist George Bernard Shaw, he made a very nice quote saying everything changes. And somewhere along that line, we need to change with that. Otherwise, we fall in danger of falling behind. And when we look at the world itself, I mean, we used to live in a very rural environment, and now things are more urbanized and more energetic. And this famous quote from H.G. Wells in The Time Machine always stood with me for many years. And we should always strive to try to welcome that change, because change is something that actually helps you grow. Some things can be hard, they can be challenging, they can really be difficult on us and mentally and physically. But when we do overcome and persevere through that, it makes us a better person. As H.G. Wells said, it strengthens our character, it increases our intelligence, it makes us better for what we do. So if we can harness all of that incredible technology and become kind of not even a master, just be able to access it and then hand it to someone else who can help us with it, or take it a step further and become a true digital master and really take it on fully, you can really help your patients dramatically, and especially when it comes to reducing the amount of treatment time, which I think is the biggest hurdle that we face. When we talk about full arch dentistry, we don't want to spend 10, 12, 13 visits with our patients. We really want to shrink things down as much as we can. And I think that's where the digital world can help us to make those visits a lot shorter, a lot faster, and we can progress from there. So when we talk about full arch treatment, we talk about different types. We have FP1 and we have FP2 and 3, with fixed prosthetic 1 and fixed prosthetic 2 and 3. And that our goal is to try to give our patients back a natural type of a teeth. And that FP1 prosthetic can really help get us to that in that full arch treatment planning. So our goal should always be to try to plan for an FP1. And in certain cases, we have to do FP2s and 3s where we have to do some bone reduction, or a patient walks in without enough bone. So we have to compensate for that. So my goal tonight is going to be try to show you how we can utilize a lot of this digital technology to hopefully do either FP1 or FP2, but hopefully try to look for more of these FP1 and not just mow down bone in a lot of these different cases. So when we talk about these full arch treatment options, that FP1, which there's no pink involved, or FP2, long teeth, FP3, a lot of artificial gingiva. When we talk about that, we're really trying to figure out how do we treatment plan it, and what do we do with that communication? How do we communicate that, whether it's within our own laboratory or in our office or with an external laboratory that maybe you're sending out your cases to. And what was really changed over the past several decades? I mean, we still take shades with Vita shade guides. Maybe you have the Vita Master Guide or a different type of a shade guide. We can take photos now with our iPhones, and we can take some digital x-rays. But, you know, the stone model days, I mean, these things are really kind of going towards that obsolete world. And taking a picture of a shade guide and sending it to the lab is nice, but there are some major types of changes of what we can utilize. So some amazing features like the Carestream 9600, which has a metal artifact reduction tool, is incredible. Having intraoral scanners has been incredible. At the bottom of your screen, you can see there's a shade matcher. This is called the Cobra. It's an absolutely fantastic shade matcher. So we've evolved a lot. We've evolved, whether it be in the digital world of 3D planning, using incredible cone beam technology to plan our cases, and we've evolved with that intraoral scanning and with shade matching. So all these things can really help us, especially when we're trying to accumulate a case and give it over to the lab for full communication. This patient came to my office, and that's an implant bridge hanging on by one implant on the top, and it's a screw retained, and she was very demanding, saying, I need my midline fix, I need this fix, and you only have one implant. We have to first start from the foundation and build everything up. But with all the things that she requested that was wrong with the implant bridge that was being held by one implant on the upper jaw, I could tell already that this was going to be a difficult patient. But ideally, what we'd like to do in these types of cases is not kill them, but we'd like to kind of like take their heads, pop it into a lab bag, and just ship that off over to the laboratory and say, here's our patient. Can you please send it back with the midline fixed, with the canting fixed, the right shade, the right architecture? And so a lot of this type of evolving has been from having to send the actual physical patient to the laboratory to being able to record everything in your own office, but give that laboratory technician the true essence of actually having a patient in their actual building. So moving from that analog world into the digital world, using things like old desktop scanners, for example, to be able to scan older impressions or older models and store them. Having the intraoral scanner instead of using an impression scan, an impression is really a remarkable thing. So the merging of these two worlds, being able to utilize both of them. If you have old stone models, get rid of the storage. Let's start scanning them with a desktop scanner. There's other things we can do with desktop scanners as well. But it's truly amazing if you have a edentulous patient, you can't get an intraoral scan. If you have an impression and you scan that impression or scan that stone model and send it to your laboratory, you're going to cut down your treatment time dramatically, whether it's for a full arch of implants or for a digital denture. So our goal when it comes to this is to create what I like to call the digital handshake, that merging of that analog and digital world. We never like to say that we're going to abandon impressions completely. I would say that maybe 1% of the time I take actual physical impressions in the office. I may need to pick up a prosthetic that maybe has a little space underneath it, and I'd rather not scan the whole arch again. I just want to pick it up with a fast setting material. There's always that case that's fully edentulous that may be a little tricky without the mandible that may not have a nice rugae like we have on the maxilla for edentulous cases. So we never completely abandon the analog. There's always that little bit that we may need, but it's the merging of those two worlds that helps us become better at what we do and gives us a much better real touch to the patient, a real touch and feel to the patient. So some key elements that are true digital disruptors in the world of dentistry have evolved over the years. Our intraoral scanners have gotten incredibly better. The Aurora Scan wireless scanner or wired scan is incredibly fast and extremely affordable. Having the cone beam from Carestream, the 9600, has been an incredible addition to my office. And that's my fourth cone beam that I've ever purchased. And I've been practicing for 20 years. Having the ability to have 3D printers now, printing my own temps, printing some types of different designs, models, whether it's aligners, all the different types of facets, night guards. It really helps us take that to the next level and cut out a lot of the waiting time that it used to be for our laboratory to deliver us over some of these products. The desktop scanner, as we mentioned before, and as well as the facial scanner, which has been an incredible game changer, which we'll talk about in a little bit as we move forward through this presentation. So when we talk about the intraoral scanner, it's really an incredible scanner. It has incredible accuracy with the Aurora Scan. Having the wireless feature is really nice. Obviously, with Wi-Fi scanners, there's always a chance that maybe it's not going to connect. Maybe you have to restart. So the wired scanner is definitely the most reliable scanner on the market when it comes to scanning. Whether you have a Trios 5, which I do have, or you have a Aurora Scan, that makes no difference. Wireless always comes with its sort of problem. So the wired scanner is always my preference, but cutting that cord is really nice. So if you can put up with the once in a blue moon having to restart a computer for a Wi-Fi scanner, it's fantastic. This scanner, the reach on it is incredible. We can get tremendously far from the actual base station. It uses the Wi-Fi 6 technology, so we're not actually stuck close with a line of sight. We can be pretty far from that base. So cutting the cord is nice. If you can spend the extra few bucks to get the wireless scanner, it's more enjoyable when you're without having to worry about that cord and wrapping it around things. It's a true joy going wireless. But regardless, intraoral scanning has its accuracy. As long as we have some markers in the mouth to scan, we can scan. The problem becomes when we deal with more edentulous cases. So the speed of the scanner is very important. So if you can capture even on a lower mandible, an edentulous mandible, if you can catch it quickly before saliva comes, before the tongue gets involved, you're going to be in pretty good shape for accuracy. And fortunately, this scanner is super fast. So I no longer use the Trios 5 that I have in my office. I sits there, collects dust. This is my go-to scanner. I use it all day, every day. I have the wireless and wired scanner in the office. My associate, he likes wired scanners, and I prefer to cut the cord with the wireless. So we talk again about these all-on-X types of cases. They involve utilizing implants with multi-unit abutments. It's a great thing to have multi-unit abutments because it gives us that passivity, that ease of not having to have a hex or a trilobe for us to be able to lute together in the mouth, whether you're doing a denture conversion or if you have some prefabricated teeth. Really makes no difference. Having that multi-unit abutment gives us the ability to move along into that world and not have to worry about engaging every single implant, just having the passivity of engaging the actual multi-unit abutment. So that being said, once we start with multi-unit abutments, we can figure out how from there can we get to from our surgery to our final much faster. So again, going into that FP1 or FP3, if we talk more about these FP3 style type of appliances where we have to do some bone reduction, the question is, why do we need to do the bone reduction? If there's some bone in the way, that's fine. We have to crater it down. If the patient comes with a denture, obviously we can't maybe go into an FP1, but if we can get them into an FP3 and level in the line, it's fine. The deal that it used to be was we need to reduce, create restorative space. That no longer makes much sense to me. When you tell me that I need 15, 16 millimeters of interarch space for one arch for the zirconia, that just doesn't compute with me. If I have a crown and I'm prepping a crown, I only need 1 millimeter of space for that crown. I don't shave down the tooth 15 millimeters. So why do we do that? And part of it is because a lot of the materials we're using have metal in them. So if you just ditch the metal completely and you go to a full arch zirconia restoration with metal free, no tie bases, no bars, you don't need to have that space. You can get down to about 8 or 9 millimeters, which is about the size of a central incisor length, 8 to 9 millimeters in length. So that's the ideal, and that's what we should be looking at. So you don't have to reduce for restorative space. Better to think about reducing in cases where you have to level and align to make a nice smooth ridge if needed, or to create a scalloping, which we'll talk about in a little bit. But when we have cases like this, where you have a huge transition zone, you have a patient with a very, very high smile line. If you look at that acrylic that you can see, that case is done terribly. They did an FP3 type of a case for a patient that needed an FP1, or they need to do the FP3 by reducing much more bone than what is in the left side of that picture. On the right side of the screen, you see a woman who's smiling and you can't see her teeth. She can have any type of restoration you want. You're not going to see that transition zone. So our goal should always be to try not to reduce too much if we don't need to avoid the unappealing aesthetics, and to keep that transition zone hidden. And if we're using an FP1, we don't have to hide it. We can actually have that. Since there's no pink transition line, we can actually just keep it and we can scallop, which we'll talk about. So a case like this, where we're kind of getting a TP of bone in the anterior region, do we go ahead and just wipe down, or do we rebuild? In a case like this, I have no choice. I have to do some bone reduction. I have to level it out because it's too high in the front anyway. I want everything flat in that region. I can't rebuild that site up in that region. But instead of throwing away the bone, we can do some interesting things. We can take a piezo, we can have everything guided completely so we know exactly where to make our cuts. And then from there, we can actually take that bone and we can harvest the bone itself. We can place some implants guided. You can see there's some thread exposed. We can do some scraping with some safe scrapers. We can scrape our actual harvested bone, and we can replace that bone and use it as what we call a Khoury plate. Similar to a bone block, we just leave a little bit of a gap in between, and we can fixate the bone in there. So no reason to just throw away and toss away that bone. We can keep it and help rebuild it, and we can get really, really nice bone formation from that. And this case was loaded the same day. So we're able to still meet our goals. We placed 6 implants, we loaded them, having the multi-unit abutments in place so we can get that passivity. And we built out that bone quite nicely. So we did do some redistribution of wealth in this case, from borrowing that bone from the upper portion, bringing it down to the lower, and be able to give that patient a nice finished product. And you can see here, even on the post-op cone beam, years later, I left in these screws and everything's looking quite nice there. the patient is extremely happy. So we can utilize these FP3 prosthetics when we need to. But the question then becomes is, do we need to do this all the time? Do we need to shave down bone for every one of these cases? You can see on these cases, I did these cases, and it kind of breaks my heart to shave down all this bone. I look at it now and I say, I wish there was another way, and there is another way. We didn't have to reduce the bone to this height, and we just didn't know any better because we were listening to engineers, not dentists necessarily, and they were telling us what to do. Nowadays, the dentists are more in control, and we can pick and choose what type of prosthetic that we want to use for our patient. So I elect to do more of a pink free. I try to go more with that fixed prosthetic 1 MISH classification and try to preserve the tissue, preserve the bone. If need be, I can shape that bone to fit. So a case like this, what we can do is actually plan on scalloping that bone and preparing it for an FP1 restoration. This was first described by my good friends, Dr. Marie Salama, Dr. Alessandro Ponzi from Italy, and with Wendy and Marco who work in Dr. Salama's office, and the extraordinarily talented technician, Lars Hansen. They created this guide of a scallop guide, shaping that bone so that we can allow for some room for the teeth. And if we put implants in the correct position, we can do quite well. So when a patient presents like this, we can follow Dennis Tornell's rule of 5 millimeters. By placing the implant a little bit deeper, we can keep that papilla. We don't have to destroy all that bone and flatten it out. We can create a scallop type architecture by removing out those teeth, reducing the bone only where necessary to create that 5 millimeter rule. And since multi-units have variable degrees of cuff heights, we can try to choose more of a straight type of a cuff. We can use a lower cuff height. If we have a straight multi-unit, choose a lower cuff height. That gives us more room. That means we have more zirconia, more thickness. If we ditch the tie bases, get rid of them, now we have extra room as well. We don't have to worry about that. So how do we ditch the tie bases? We just go with some specialized screws. There are so many of them out there. Des has them, Vortex, Rosen screw. You have the Abernathy Powerball screw. So many screws on the market. Sin has a screw as well for metal-free zirconia. Now, if you choose a straight abutment, that's your smallest cuff height. That's going to be the go-to. If you need to do some angulation, that's fine too. But keep in mind, once you start angling implants, your cuff height has to change. Now, you can't necessarily have a 1.5 millimeter cuff height. You go towards 2.5 millimeters as your starting point. So that means the implant should be going even deeper into the bone. And especially if you're going to go into these severely angulated to get 30 degrees, now you're looking at starting out at a 3.5 millimeter cuff height. So the implant should be even deeper on those cases. So you have to think about that, because otherwise the multi-unit's going to be showing. And if you're trying to pick a pink-free case, you need to bury that implant a lot deeper on your plans. So a case like this, we can change angulation. We can use all different types of implants on the market for this, but having the right type of angulation, having the right type of cuff height is the most paramount part to being able to create a truly natural type of aesthetic result. And we can scallop the bone. We can make this plan. We can digitally scallop on the software. And in this case, I'm actually going and using a technique called socket shield or partial extraction therapy, where we're not going to actually extract all the teeth. We're going to just keep part of them. But using the scallop guide to show me exactly where I want to reduce the bone to, so that I can end up seeing exactly where the teeth should end up being. We can know the distance between the base of the teeth and to where the roots are going to be. So it should look somewhat like this, where we're using type of a guide. If you can freehand it and you have the ability to, great. You don't need a guide. You can do it without that. And at this point in my career, I am able to do that. And we can create really nice aesthetic results by having the scallop guide and not have to go into this flat, straight out bone reduction, reducing all that bone, which really does break my heart when I do see those cases when they don't have to be. So having surgical guidance, using the right technology, just trying to get more of an FP1 solution really gives us a very nice leg up on the competition that's out there, the Clear Choices of the world, the All-on-4s of the world that aren't doing those. And we can do these cases with flaps, or we can even use them flapless. by going through the tissue. So we have two cases here. On the one side, we're going to actually make a flap. On the other side, we don't have to make a flap. We can use the guide flaplessly. So it doesn't have to be a very difficult type of a situation. So on the left side where we're making a flap, we'll lift it up. On the right side, we're going to just punch through the tissue, and we can do a surgical guide that way as well. The key is to get good stability of the guide. So I like to use guides like this. This is the Chrome Guided Smile Guide. And this gives me some really nice stability of a foundation base that I can work off of, so I can create that scalloping. So again, it can be freehanded or it can be a guided scallop, but we can do really wonders once we can get to that point where we can shape the bone and create the distance between the multi-unit abutment and the actual start of the teeth. So on the one side, I'm still placing the guide. On the other side, I'm already extracting teeth. And this is going to be an all-on-X case. I like to place roughly 6 to 8 implants on average when I'm placing, doing these full arches. But on one side where I'm doing it flaplessly, I'm already extracting teeth. I'm using my favorite instruments, which from TBS, the Frings forceps. They're really nice spring-loaded forceps. And we can extract teeth with ease with these forceps because they have a great grip. On the other side, we're just beginning to start extracting teeth. And that's because we actually had to make a large flap. In that case, this is Fabio. In Fabio's case, he has a much more higher degree of aesthetic demand here because his teeth were a little bit short. So we have to scallop it using a guide because I just feel it's too difficult not to. In this case, I'm also doing that partial extraction therapy to remove part of the lingual aspect of the tooth and keeping the buccal aspect so we don't have to shave the bone too much. We can keep it to the right height and we won't lose bone because that root is remaining there. So we can do some of those extractions there, and eventually we can start scalloping. So we can either do it free-handed. On one side, you see the free-handed aspect of scalloping. On the other side, a guided aspect of scalloping to reduce the bone height to the correct level. And depending on the case, you can choose to do this all free-handed, or you can choose it to go all guided. Truly up to you and how you feel your skills are. If you're not placing implants, you can certainly learn how to and learn these cases. It's become a tremendous part of my practice, and that's pretty much all I do now is implants and restoring those all day long. So having that guided aspect can really have full control. This is a guide that we made with again, Rodental Chrome Guided Smile, and you can see the scalloping, which was that proof of principle article by Salama. Regardless which way we went, you can see just how nicely the tissue wants to heal. We start to create papilla. We're guiding the smile completely, guiding the tissue, guiding the bone. And this is just 2 weeks after we've done the surgery. You can see as we follow up how nice and healthy the tissue looks, whether we buried those parts of those roots or we extracted everything, we can still control it by scalloping. And that's the key. It's not about anything more than just understanding the basic rules that Dennis Tarnow did put out so many years ago, that 5mm rule of where the interproximal height of bone is going to meet in the contact point. If we keep that 5mm and below, we're always going to be able to create papilla. We don't even have to do any gingival grafting. It will just naturally occur. So on both of these cases, you can see we placed 8 implants on the top on both of them. Whether we buried the roots or not, we got really nice aesthetic results for the patients. And these are long-term results. These are both about 5 years old each case, and they've been working out extremely, extremely well. So I like to say that we're changing lives one smile at a time. And in some cases, you may say one arch at a time, but that's our goal, is to be able to help patients and give them that real cosmetic aesthetic desire that they truly want, and without having to mow everything down and just treat it as an FP3. But